With us today is Dr. Ileana Piña, Professor of Medicine from Albert Einstein College of Medicine in the Bronx, to discuss hyperkalemia. Welcome, Dr. Piña.
Thank you.
Dr. Piña, RAAS-induced hyperkalemia is a barrier to implementation of long-term RAAS therapy. How would you suggest implementing treatment with potassium binders?
So it is a problem to have the hyperkalemia. I was just on this weekend, and I had at least 3 patients that I confronted exactly with this issue. There is a lot of concern from clinicians about potassium levels with a very rapid rush to judgment and do something, let's do something. I think we need to understand that part of the physiology and pharmacology of the RAASi system, blockers, is in fact the increase in potassium. And I've taken a look at our own patients in our clinic and some that are in studies, and we are stopped from using full RAASi, which to me includes an ACE or an ARB and spironolactone, because we're using a lot more spironolactone. There's about 20% of the patients that I cannot put on, say, spironolactone added to the ACE or the ARB because of hyperkalemia. So it really is an issue. And the way that we address it is usually make sure that, for example, the patient isn't using a salt substitute that's made up of potassium, like some of the salt substitutes bought at the grocery store that are sitting next to the salt are really pure potassium salts. Number 2, are they ingesting high potassium-containing foods, such as yesterday one of the patients that I was being called about because his potassium was high had like 3 cups of orange juice sitting at his bedside. He already had 1 banana and had another one sitting there to eat, and also had a little plate full of watermelon, a couple of other like honeydew. They're all high in potassium. And so it's really important to address that with the patients. However, even with that, and patients who can be very compliant and be careful, we're also limiting good foods for them, because a lot of, like avocados and some greens, also have a lot of potassium, and we are encouraging patients to eat healthier, more fruits, more vegetables, and there goes the potassium with it. So this happened yesterday, that the nurses on the floor and the PAs had already been thinking of how they were going to lower the potassium on these 2 patients, and they already had mixed up the SPS for them, and the patients are looking at me saying, do I really have to drink this because it looks so bad? And I don't blame them.
Would you advise intermittent treatment to attain normal kalemia as needed, or as a chronic therapy?
So, when we use dietary restrictions and, unfortunately having to stop certain drugs, it should be something that we do all the time, because we want the patients on the drugs. In other words, I want them on spironolactone because adding the mineral receptor corticoid antagonist to the ACE and the ARB has been shown to have significant benefits in mortality, in rehospitalization. So it's a very important add-on for us. And it's also a very inexpensive drug. It's like 10 or 15 cents a tablet. So it really troubles me when I can't use it. And I would think that, treating the potassium should be there as long as we're giving the drug.
So is there data supporting long-term treatment with potassium binders?
So right now we have 1 potassium binder on the market called Patirimer, and the Patirimer data does have a study that showed that there was maintenance of normal kalemia for a year if the drug had been given appropriately. I think we're going to learn much more about how to use this drug as we really start rolling out and using it, particularly in the outpatients. The questions that still revolve are, how often should we check the potassium? Should we check it monthly? Should we check it weekly? Or once you get them on a steady course, can you just prescribe the drug daily and let them take it once a day? So I think we're going to learn a lot as the months go on now that the drug is available, and we're going to learn how to use it better in the outpatient setting.
So are there any concluding thoughts or takeaway messages from this?
Well, I think concluding thought for me is I have been very excited that we're going to have potassium binders that are better than SPS, because I hate doing that to the patients. I hate sending them to the emergency department either to get it orally or to get it, rectally. It's so unpleasant. It can use another emergency department visit, which is costly and time-consuming. So that if I can treat this in their own home with something simple, I really welcome that.
Thank you, Dr. Piña, for spending some time with us today.
My pleasure. Thank you.